So we move over right to the amongst us an eminent cardiologist, Dr. Supratip Kundu. So over to Dr. Supratip Kundu to take over the podium and conduct the class today. Go ahead.
Yes, sir. Okay. Let's start with this. First of all, it is the definition of arterial pulse. It is rhythmic expansion of arterial wall due to transmission of pressure waves that travels along the arteries due to forceful ejection of blood during systole. Number one, first thing I want to remind you that it is the pressure waves, and it is the pressure waves which travels along the arteries and creates this expansion of arterial wall, which is felt as pulse. So this is one important picture. This is pulse is basically produced by two different types of waves. One is forward traveling pulse wave, and second one is the backward traveling pulse wave. So this is forward traveling pulse wave, and this backward traveling pulse wave are mainly from the reflected waves from the bifurcation points. So these are for central arteries where forward traveling pulse wave and the backward traveling pulse wave are out of phase, and that's why it produced this type of graph for pulse wave. And this is for distant arteries, or rather stiff arteries, where forward traveling pulse wave and backward traveling pulse wave are very nearby, and that's why they are mostly in phase. This is the backward traveling pulse wave, and this is the forward traveling pulse wave. So this will produce the picture like this. Now, coming to the structure of a pulse, there are three types of wave in pulse. Number one, it is the percussion wave, which is produced due to ejection of the blood during systole. This is mainly the forward wave. And second thing, it is the tidal wave. Tidal wave is during systole, and this wave is produced by reflected waves from the upper part of the periphery, as well as forward wave from forward propagating waves. So I am coming back to this. Now you can see the first slide. Now you are able to see the first slide?
Yes.
Second slide?
Yes.
Okay?
Yes.
Third slide?
Now moving.
Yes.
Yes, perfect.
Okay.
Okay.
Perfect. Okay. Please go ahead.
Okay.
So you can start from.
So, okay. So now I am coming to the structure of this pulse. So this one, first one is the percussion wave, second one is the tidal wave, and third one is the dichrotic notch. So percussion wave is mainly produced by the ejection of the blood, and it is mainly due to the forward propagating pressure waves. The tidal waves is basically the combination of forward propagating waves as well as the reflected waves from the upper part of the periphery. And then comes the third wave, which is basically the dichrotic. Then comes the third wave. It is the dichrotic notch and the dichrotic waves. So this is mainly due to the reflected waves from the lower part of the periphery. So I am coming back to this structure again. So this is the forward waves, and this one is the backward traveling waves. So when it is central arteries, the two waves are out of phase. That's why they are giving rise to this type of picture, like percussion wave followed by tidal waves and followed by dichrotic waves. And when these two waves comes closer, that means in a distal arteries, then they will increase the width of the increase the amplitude of the pulse, and it is mainly from the distal arteries. So this is the structure of pulse. Can you able to see this? Everyone is able to see this?
Yes, sir.
Okay, so this is the structure of the pulse from central arteries to peripheral arteries. In central arteries, it is mostly prominent percussion waves, and in peripheral arteries, that tidal waves becomes the important part. So what is the difference between central pulse and the peripheral pulse? The main difference between the central and peripheral pulse is the peripheral pulse becomes stiffer. The incisura in the central arterial pulse is replaced by smoother dichrotic notch, and there will be prominent dichrotic waves in the peripheral pulse. So next thing, how to examine the pulse. So three important points you have to remember. Forearm should be semi-pronated, wrist is slightly flexed, and gently compress the radial artery against the radius. So these are three important points. You have to semi-pronate the forearm, wrist should be slightly flexed, and gently compress the radial artery against the radius. Now, what are the points you have to look out for in pulse? Number one, it is rate. Next, rhythm. It is third is volume. Fourth is character. Number five is condition of the vessel wall, and number six is equality, that there is radio-femoral or radio-radial delay, and all the peripheral pulses are palpable or not. One important thing, how to look for condition of the vessel wall. It should be looked by three-finger method. Place three middle fingers on the artery, proximal index finger obligates, distal ring finger empties the vessel, and middle finger palpates and fill the vessel wall. So this is the picture how you should palpate the condition of the vessel wall. The vessel wall is normally not palpable, and if it is palpable, it suggests advanced atherosclerosis, mainly in old age or in diseases like hypercholesteremia. So this is another important thing for exam. What are the special character for the pulse? Number one, anacrotic pulse, water hammer pulse, pulsus bisperiens, dichrotic pulse, pulsus paradoxus, and pulsus alternans. These are special type of pulse. Next, I just uploaded this picture from Harrison's book. So these are different types of pulse. This is the norm. First, A is the normal pulse. A is normal pulse. Second, here you can see it is a normal pulse in the distal arteries. Here you can see these percussion wave followed by tidal waves and the prominent dichrotic waves. It is a normal pulse for distal arteries. Now, B is the anacrotic pulse. Anacrotic pulse is mainly slow rising pulse, and this pulse is mainly seen in aortic stenosis. Number 3 is the Bisperiens pulse. Bisperiens pulse is the double peaking pulse, and both the peak should be in systole. one important thing you have to remember: for every pulse, the percussion and tidal waves, these are in systole, and the dichrotic wave is in diastole. But for Bispherians pulse, there are two distinct waves. Pulse is seen in two conditions: AS with air and HOCM. These are two special conditions where Bispherians pulse is seen. And Bispherians pulse is not synonymous with water hammer pulse. And another important double picking pulse is dichrotic pulse, and dichrotic pulse is mainly seen in acute LVF and severe sepsis when there is severe vasoconstriction. And this second dichrotic wave is mainly due to produced by the reflected waves from the periphery. So there are three types of double picking pulse. Number one, pulsus Bispherians in AS with air, pulsus Bispherians in HOCM, and third one is the dichrotic pulse in severe sepsis or acute LVF. So this is the method of examining water hammer pulse. Now, what is the special character of water hammer pulse? Water hammer pulse is seen mainly in aortic regurgitation. In aortic regurgitation, often there is severe vasodilation in the peripheral arteries, and due to increased end-diastolic volume, as per Starling's law, there is forceful ejection of the blood, and it gives rise to a sharp tapping character of the pulse, which often touches the finger and then goes. So what is water hammer? Why this name is given? Because it is actually according to the name of the toy, in which the toy is half filled with a liquid, and when the toy is suddenly inverted, it gives a sudden thud or sudden inrush, and it quickly passes when the toy is moved up and down or inversely. So this is a similar character of the pulse. The initial quick upstroke is mainly due to huge amount of ejection volume of the blood, and the quick pass off is mainly due to peripheral vasodilation as well as due to aortic regurgitation. Next, I also want to discuss these two pulses. Next is the pulsus Bispherians. In pulsus Bispherians, what is the mechanism of pulsus Bispherians in AS with AR? This is another important point. In AS with AR, there will be severe vasodilation. Hello, am I audible? Hello.
Yes. Yes, sir.
Okay. In pulsus Bispherians, in AS with AR, there will be severe vasodilation, and when there will be huge ejection of the blood through ascending aorta, there will be Venturi effect. Do you know what is Venturi effect is? Venturi effect is when there is a rush of fluid through a closed tube, there will be sudden decrease in the lateral pressure, and that will cause indrawing of the lateral wall of the aorta. Indrawing of the lateral wall of the aorta, and that will cause the temporary decrease of the that will cause temporary downfall, and later the ejection again picks up, and that will produce the second peak. This is the mechanism of pulses variance in AS with AR. And what is important thing, both the peak are of same height. And what is the mechanism of HOCM? The mechanism is dynamic alveolar obstruction. Initial forceful ejection, next initial forceful ejection producing the initial peak, followed by dynamic alveolar obstruction in HOCM, and that will lead to decrease of the peak or downfall, and followed by in the latter systole there will be continued ejection again, producing that dome shaped peak again. So in HOCM, the two peaks are not of same height. One peak is very sharp and another peak is rather dome shaped, whereas in AS with AR, both the peaks are of same height. So next is the dichrotic pulse. I have already told the dichrotic pulse is mainly due to severe vasoconstriction, and it is produced mainly in the state where there is severe vasoconstriction like acute LVF or severe sepsis in stage. In that condition, dichrotic pulse is produced. Whereas in sepsis, initially there is vasodilation followed by in which there is high volume pulse, and followed by in later stages of sepsis there will be vasoconstriction leading to this dichrotic pulse. Next is pulsus paradoxus is basically inspiratory decrease in the decrease in the pulse wave. It is more than 10 millimeter decrease during inspiration. And why there is inspiratory decrease? Generally, during inspiration, the volume of blood in the right ventricle increases, which leads to bending of the septum towards the left side, and this will lead to decrease in the pulse volume from the left side, and that will gives rise to pulsus paradoxus. It is basically a normal phenomenon, and it is exaggerated in condition where the right ventricle cannot distend too much, like the conditions like constrictive pericarditis or pericardial tamponade or RVMI, or in conditions like pulmonary embolisms. In all these conditions where right ventricle cannot dilate too much, and they will compress the left ventricle, and this will causes the pulse this will cause the decrease in pulse pressure. And next is the pulsus alternans. Pulsus alternans is mainly seen in acute LVF. Pulsus alternans is mainly seen in acute LVF, and in this condition it is actually the alternate high volume and low volume pulse, and both the pulses should be measured with sphygmomanometer. And in sphygmomanometer, when we start decreasing the BP cuff at initial phase, during the carotid cuff sounds are only heard at the time of expiration, and followed by when we start decreasing the BP cuff and we start deflating the BP cuff, then it will all the carotid cuff sounds, the number of carotid cuff sounds will increase. So the gap where the some carotid cuff sounds are heard and the phase where all the carotid cuff sounds are heard, that is the gap basically which is the pulsus paradoxus. Now I am coming to this part, how to palpate the peripheral pulse. This is basically an examination. So this is the method of palpating the carotid artery. Carotid artery, how to palpate the carotid artery? Basically, it is palpated at the medial border of sternocleidomastoid and upper border, basically the junction of medial border of sternocleidomastoid and upper border of thyroid cartilage. Next, and it is palpated with the with thumb. Next is the radial pulse. It is palpated with 3 fingers. Next is the brachial pulse, and it is palpated just medial to the biceps brachii tendon. And it is better to flex the hand during the palpation. This is basically method of examination, and it is asked during the exam. And this is femoral pulse. Femoral pulse is the midway between anterior superior iliac spine and symphysis pubis. And this is the posterior tibial pulse, which is palpated just behind the medial malleoli, and the dorsalis pedis is palpated just lateral to extensor tendon. And one important thing, often posterior tibial pulse or dorsalis arteris pedis should be is absent in about 10% cases, but we should look for the equality. That means when dorsalis pedis on one side is absent, if it is normal, then the other side should also be absent. Okay, it is the equality is important. If it is unequal absence on either side, then we have to suspect it as pathological. And last important examination method I want to show, it is the radio-femoral delay and radio-radial delay. For radio-femoral delay, we have to radio-femoral delay is particularly important for coarctation of aorta. And when we do the maneuver or when we check for radio-femoral delay, one important thing we should remember that we need to bring the hand close to groin so that we can appreciate it promptly, the delay. And when we observe the radio-radial delay, then we have to bring 2 hands closer. That is most important thing. Radio-radial delay is important for tachyarteritis. Radio-femoral delay is important for coarctation of aorta. And last of all, one important thing, it is the time at which pulse wave arises after each cardiac systole. For carotid, it is 30 milliseconds. For brachial, it is 60 milliseconds. And radial, it is 80 milliseconds. And femoral, it is 75 milliseconds. So that's all about pulse. And Amida, hello. Yes. হ্যাঁ বলছি পালসের উপরে কোশ্চেন কি আমি এখন তোরা করে নিবি নাকি আমি শেষে গিয়ে কোশ্চেন করবি পালস আর জেইপির উপর?
এখন করব না বেটার।
হ্যালো,
এখন করলে ভাই বেটার।
ওকে ফাইন, কন্টিনিউ। আমি বুঝতে পারছি না যে আমি কতটা বোঝাতে পারলাম। এবার আস্তে আস্তে জিনিসগুলো ক্লিয়ার কর, যে জিনিসগুলো বুঝতে পারিসনি সেই জিনিসগুলো আমাকে ক্লিয়ার করে, একজন করে কোশ্চেন। একজন করে।
একটা রিকোয়েস্ট হচ্ছে, আমার মনে অনেক পার্টিসিপেন্ট আছে, তো আপনি কোশ্চেনগুলো কিছু কোশ্চেন চ্যাটে ইনভাইট করুন, দ্যাট উইল বি বেটার। না হলে হচ্ছে সিকোয়েন্সে একটু প্রবলেম হবে বলে আমার মনে হচ্ছে। মানে
আচ্ছা আমি চেষ্টা করছি, 1 মিনিট। আমি আসলে
it's better if questions are written in the chat.
Now it is okay. Chat. So first important thing, what is pulsus bisperiens? So this is pulsus bisperiens in AS with AR. In AR, the basic pathology is LV end diastolic volume is increased. And how LV end diastolic volume is increased? It is due to the ejection fraction of air, because a portion of blood comes from the aorta to LV. So this will increase the LV EDV. So when LV EDP will increase, so it will lead to increased force of contraction according to Starling's law. So it will cause increased ejection force of blood through the aorta. In pulse, in AS with air, pulsus bisperens is produced. That means there are two systolic peaks. Now, what is the mechanism of this pulsus bisperens in AS with air? In air, there will be increased end-diastolic volume. Increased end-diastolic volume means increased force of contraction due to Starling's law. So that will produce the first peak. Now, when there is increased force of contraction and increased velocity of blood through the ascending aorta, then the lateral pressure will decrease. Lateral pressure will decrease by Venturi's effect. And when there is lateral pressure will decrease, there will be indrawing of the aortic wall. Indrawing of the aortic wall, and that will produce this Hello? Am I audible?
Yes, sir.
Okay, that will produce the temporary dip, and this temporary dip will again increase the LV-EDP. This will again increase the force of contraction, and there will be secondary peak. So these two peaks are of same height, and in HOCM, the dip is mainly produced the dynamic LVOT obstruction. In HOCM, there will be asymmetric septal hypertrophy. So when the force of contraction of LV will increase, that will draws the mitral valve, and that will produce the dynamic LVOT obstruction, and that will decrease this dip. That will cause this dip, and after this dip, LV-EDP will again increase, and this will produce, but it is not as much as AR, so there will be a dome-shaped pattern. In HOCM, these two peaks are not of equal height, and in AS with AR, these two peaks are of equal height. So it is audible, okay? Hello? Hello?
Yes.
It's
Sir, it is audible.
Okay. Okay, I have already explained this. Next question, please repeat the questions. Okay, next. Any questions? Okay, fine. Okay. So, first, forward wave and backward wave. Forward waves are produced mainly due to ejection of the blood through aorta. So these are forward waves. So when it is central arteries, and backward, next comes to backward wave. Backward waves are mainly produced due to reflection of the pressure waves from the bifurcation of the arteries, and reflection is more in case of distant arteries. That means when we take the pressure from the pressure waves from the ascending aorta, the first bifurcations are very distant. Okay, and mainly so this forward wave and this backward waves are out of phase because they are widely separated in times. Suppose the waves are reflected from the brachial arteries, and the forward waves are you are measuring the wave in the ascending aorta, and the first wave reflection is from the brachial arteries, and that's why it is the time gap. Basically, your wave has to reflect it from the brachial arteries when you are measuring the pressure in ascending aorta, and you are getting forward wave as soon as the LV ejects. So it is suppose time t1 and it is time t2. This t1 t2 is mainly due to distance of the aorta from the distant arteries. So as we move peripherally, suppose you are getting the pressure pulse from subclavian arteries. Now your forward wave is this. This is at time t1 and your waves are reflecting from the brachial arteries, and that's why these two waves are very in phase. And this, when these two waves are in phase, this will produce the augmentation. This will produce the augmentation even after the percussion waves, and this is known as augmentation index. And that's why the pressure in the central arteries, mainly these pressure waves are due to percussion waves, and here it is stiffer, and the pressure wave domes here are not very stiffer. Am I able to explain? Pulses experiences? Oh. Okay. Just a minute. Apart from ASAR, pulses experiences also find in HO. You can also find pulses experience in HOCM. Okay. And next question is, please repeat the measurement of pulses alternance by sphygmomanometers. Suppose you are deflating the cuff at pressure of 140. At pressure of 140, you are getting n number of port cuff sounds, and at pressure 130, you are getting 2n number of port cuff sounds. That means, and this is irrespective of respiration. That means you are getting that means you are getting pulses alternance. And when you get this phenomenon with respect to respiration, that means in defined phase of respiration, suppose you are getting n number of port cuff sounds during expiration and 2n number of port cuff sounds during inspiration, then it is known as pulsus paradoxus. Then it becomes a pulsus paradoxus, because pulsus paradoxus is a phenomenon dependent on respiration. Am I audible? Hello?
Yes, sir, you are audible.
Yes, sir.
Clearly audible.
So measurement of pulsus alternance, is it clear? Measurement of pulsus alternance, is it clear? Okay, fine. And forward and backward wave, is it clear? Forward and backward wave. Okay, fine. Any other question? Okay, Venturi effect. Venturi effect is it is not only for medicine, or it is not only for cardiology, or it is not only for physiology. It is just about fluid dynamics. When a fluid ejects through a closed tube and the forward velocity increases, then the lateral pressure will decrease. It is constant for all the fluids, and this is known as the Venturi effect. I think so. It is principle of Venturi. It can be, but it is Venturi effect is basically the decrease in the lateral pressure, and this decrease in lateral pressure, basically it creates a vacuum and it indraws the aortic wall, and that's why there is the dip. That's why the dip is produced. In HOCM, the dip is produced by dynamic LVOT obstruction, and in AS with air, the dip is produced by that Venturi effect particularly. Anything else? Oh, what's the difference between bispherians and bigemini? Actually, bigemini is mainly produced during VPCs. Pulsus bisperiens is double picking pulse, and pulsus bigemini is also bigemini. The terms mainly we use in case of ECG. Pulsus bigemini is one. It may be one normal volume pulse along with another low volume pulse produced due to VPCs. But bisperiens, in bisperiens, these are two peaks. These two peaks are due to systole, and bigemini, these are two different pulse. These are two different pulse, and bisperiens, these are two peaks in single pulse. Am I clear, Suraj? Hello, am I clear, Suraj? Okay, anything else? Should I move to JVP? How
Yes.
does AR and AS occur together? It can be, because and it is particularly more often seen in case of rheumatic heart disease, because in rheumatic heart disease it is rather puckered valve, which is rather fixed orifice. It doesn't close properly or it doesn't open properly. So there will be AS with AR. Often you can see there will be severe AS with moderate AR. Okay. So should we move? Hello?
Move to the next topic.
Okay, fine. My slides are visible?
Yes, sir.
My slides are visible? Okay,
Yes, sir.
fine.
Yes, sir.
They
Okay.
are changing.
Okay. Now coming to JVP. Letting top of vertical column of blood in the right internal jugular vein that reflects the phasic pressure change in the right atrium. So pulse is basically the systolic function of left ventricle, and JVP is basically the phasic pressure change in the right atrium. So JVP is basically the backward pressure from the right atrium, and pulse is basically the forward pressure from the left ventricle. So why IJV? It is important question for exam, because IJV has a direct course to RA. IJV is anatomically closer to RA, and IJV has no valves. Okay. And external jugular vein is more superficial and prone to kinking and partial obstruction as it traverses through a deep fascia of the neck. And vasoconstriction secondary to hypertension can make EJV small and barely visible. These are all the points you should remember. This is very important question. Okay. Okay. Next is why right IJV. Right IJV veins extends in almost straight line to superior vena cava, thus favoring transmission of hemodynamic changes from the right atrium. Left innominate vein is not in a straight line and may be kinked or compressed. Okay, that is the main reason. Right IJV is straight. Number 3, this is important. How to measure JVP? Nowadays it is told that JVP should be measured in sitting position. Why sitting? Because it is easier to measure. You can directly measure this height from sternal angle to the height of the JVP. And when it is in 45 degree, normally the JVP is just behind the clavicle. So at 45 degree, anything above the clavicle is abnormal. And normally you should measure the JVP from the sternal angle, and the center of the right atrium is at a distance of 5 cm from the sternal angle. Next, how to differentiate from the carotid pulse. It is also important question for exam. That's why I have taken all these slides and you have to mug all these up. And JVP is better visible, carotid pulse is better palpable. Next, it is the oscillatory waveform with inward movement. It is mainly inward movement. Inward movement is very important. And for carotid pulse, it is rapid, outward, jerky movements. Am I audible? Just, am I audible?
Yes, yes, yes.
Okay, okay. Next, 2 peaks per heartbeat, 1 peak per heartbeat, carotid pulse, for carotid pulse. And seen in the triangle formed by 2 heads of the sternocleidomastoid and the clavicle, and seen internal to the sternocleidomastoid. And it is sorry, it is written opposite. Basically, JVP is dependent on respiration and carotid pulse is mostly independent of respiration. Sorry, check this point. And carotid pulse mainly varies with position, and carotid pulse doesn't varies with position, and JVP is varies with position. And for JVP mainly dependent on the abdominal pressure, and the carotid pulse doesn't depend on the abdominal pressure. And JVP generally obliterates with the pressure at the root of the neck. Sorry, this slide is some problematic. So this is the measurement of JVP. This is important examination. This is from the height, vertical height from the sternal angle. This is something when you have to do when you measure the JVP at 45-degree angle. Next, it is one important thing. Just I want to highlight this point. Add 5 cm to the measured central venous pressure, since right atrium is 5 cm below the sternal. So you have to measure the vertical height from the sternal angle, and you have to add 5, and that will give the pressure of suppose there is height of 5 cm. So it will be 10 cm of water or blood, and that will that is the equation how you can convert the pressure into millimeter of mercury. And CVP should be less than 7 millimeter of mercury. Suppose it is 10 centimeter of blood, 10 centimeter of blood, that means you have to divide it by 1.36, and it will give you the millimeter of mercury pressure. Okay. So upper limit of normal is 4 centimeter above the sternal angle. I am skipping this slide because it is already I have said. You can also measure the JVP in sitting position. Actually, during our DM period shift, our teachers used to tell that JVP should be seen in sitting position. This is new concept, and also you can check this in 45-degree. Maybe it is for your exam. Next is one important thing I want to remind, that is abdominojugular reflex. Abdominojugular reflex is elicited with firm and consistent pressure over the upper portion of the abdomen, preferably over the right upper quadrant, for at least 10 seconds. And a positive response is, just look at this, a sustained rise of more than 3 centimeter in JVP for at least 15 seconds after release of the hand. That means up to 10 seconds of firm mid-abdominal pressure, which causes a sustained rise of more than 3 centimeter in JVP for at least 15 seconds after the release of the hand. That means you press for 10 seconds, then release, and it will cause the rise of JVP for at least 3 centimeter for at least 15 seconds. That is positive hepatojugular reflux. So what does it signifies? Just two important things. Number one, silent TR and latent right heart failure. So when it can be false negative, it can be SVC or IVC obstruction or Budd-Chiari syndrome. Now, coming to this very important picture. Before going to this, I just want to explain the basic waves of JVP. Am I audible?
Sir, clearly audible. Yes,
Am I
sir, yes,
audible?
sir.
Okay, fine. So there are three basic waves in JVP. There are three positive waves: A wave, C wave, and V wave. And there are two negative waves, two or three negative waves: X descent, and so A wave is mainly due to atrial contraction. So it will follow the P wave in ECG. P wave is atrial depolarization. So this X descent is due to atrial relaxation. This A wave is due to atrial contraction, and this X descent is due to atrial relaxation. Followed by C wave. C wave is mainly due to left ventricular contraction. Left ventricular contraction will lead to bulging of the tricuspid valve from RV to RA, and this will produce the C wave, and followed by and this X dash is produced when there is ejection phase begins, and this ejection phase will decrease the pressure in RV, and this will produce the X dash descent. And this V wave is produced mainly due to atrial filling, right atrial filling, and this Y descent is produced when there is right atrial emptying from right atrium to RV. Audible? Okay.
Yes, sir, audible.
Hello?
Audible.
Okay, fine. So this C wave is mainly due to left ventricular contraction, so it will follow QRS. It is quite obvious. And when there is T wave, this QT interval is basically isovolumetric phase, and there will be repolarization during this period. So it will be associated with diastole. So VY phase is basically ventricular diastole, because the ventricle is getting the blood from the atrium. So it is this phase. So it is corresponding with this phase of the ECG. Next slide. Next, it is one important slide. So what is the relationship of JVP with the heart sound? So A wave is basically simultaneous with the fourth heart sound. So it is basically late rapid filling phase in the ventricle. C wave is basically the first heart sound. First heart sound. Why it is associated with first heart sound? Because the ventricle starts contracting and it will close the tricuspid valve. Is coinciding with the C wave. The second heart sound. What is second heart sound? Second heart sound is basically the ventricle starts relaxing and the pressure of blood in the aorta exceeds that of the ventricle. So it is just after the systole. So what is X descent? X descent is basically the ejection phase. X descent, this descent is basically the ejection phase, and after this ejection phase the second heart sound is produced. So it will coinciding it occurs just before the V waves, and after the left ventricular contraction has ended and the diastole has started, then before that the atrial relaxation will set in and there will be V waves. So during ventricular relaxation, the third heart sound, the early rapid filling phase, during the early rapid filling phase, third heart sound is produced. So the third heart sound basically corroborates with Y descent. So I am not going all these slides, these are repeating the same thing, and you have to basically remember this picture. So I am audible. This slide is very important.
Yes, sir,
Hello?
you are audible. Carry on.
Okay,
Carry on, you are
fine.
audible.
Okay. Now I want to give some important tips for identifying, and these two important things you have to remember. A wave occurs just before the first heart sound or carotid pulse. So just carotid pulse is basically the ejection phase. Carotid pulse is ejection phase. As you can remember, carotid pulse occurs 30 milliseconds after the apex beat. 30 milliseconds. It is just this beat. So it is basically ejection. So A wave occurs just before the first heart sound or carotid pulse, and C wave succeeds S1 or simultaneous with carotid pulse, and you can't see C wave. Only the condition in which you can see C wave is the TR, and the X descent occurs just prior to second heart sound, while the Y descent occurs after the second heart sound. These two important points. Second heart sound, you can identify the negative waves. First heart sound, before first heart sound, you can see the A wave, and V wave occurs just after the arterial pulse. So it is if the positive wave occurs before the arterial pulse, it is A wave. If after the arterial pulse, then it is V wave. And X descent for S2, if it occurs before the second heart sound, it is X descent, and if it is occurs after the second heart sound, it is Y descent. So for identifying the positive waves, you have to check the pulse. So if before it is A wave, and if after it is V wave, and for checking the negative waves, you have to see the second heart sound. So you have to put the stetho and you have to look for negative waves. Clear? This slide is important. Are you audible?
Yes, sir, you are audible, sir. And yes, sir,
Okay.
Yes, sir, fine, sir. Audio is okay.
This slide is very important. For identifying positive waves, you have to check for pulse. If before it is faster, if it is A wave, and if after it is V wave, and for second heart sound, with second heart sound, you can identify the negative waves. If before it is X descent, and if after it is Y descent. So now coming to the abnormalities in A wave. A wave, there are mainly three types of abnormality, or two types rather. One is canon A wave. Canon A waves is basically when the atrium contracts against a closed mitral or tricuspid valve, or it contracts against a resistant or stiff ventricle. So canon contracts against the closed valve, particularly in case of junctional rhythm, or in CHB, or in VT. You can see canon A waves, because at that time the atria and the ventricle contract simultaneously. And when you can see elevated A waves, when it contracts against a narrowed valve like tricuspid stenosis, or it contracts against a stiff ventricle like pulmonary stenosis. And when you can see A waves, you can't see A waves, it is atrial fibrillation or atrial standstill. There are some conditions where atrial standstill occurs. We need not to go into that. So elevated airwaves I have already discussed. I am not going into all these details. You will get these slides. And just one important thing: what is regular canonier airwaves and irregular canonier airwaves? Regular canonier waves you get in case of junctional tachycardia, and irregular canonier waves you see in case of AV dissociation. AV dissociation seen in two conditions. One is CHB as well as in ventricular tachycardia. What is the difference between AV dissociation in CHB and ventricular tachycardia? In ventricular tachycardia, the number of V waves is more than A wave. That means number of beats in ventricle is more than atrial beats. And in CHB, number of atrial beats are more than ventricular beats. So, am I audible? Okay.
Yes, sir. Okay, sir. Audible, sir.
Okay. And then comes to V wave. So elevated V waves, the most important cause is tricuspid regurgitation. It can also be fluid overload. So in tricuspid, one important thing I like to mention, in tricuspid regurgitation, it is mainly CV wave. So in tricuspid regurgitation, there will be obliteration of the X descent. So why X descent is produced? X descent is produced when there will be ejection phase in the ventricle. So in tricuspid regurgitation, the due to the leaking valves, the right ventricle will empty into the pulmonary artery as well as the in atrium. So this whole X descent will obliterate, and the amount of obliteration of X descent will signify the how severe the TR is. That means if there is only X descent obliteration, then there will be mild TR. If there is near total obliteration of X wave, there is moderate TR, and if there is CV waves, then there is severe TR. These are the method by which you can quantify TR. But there are some fallacies. That means if the ventricles is stiff or if the atrium is accommodative, then you can't appreciate all these changes. So another important cause is right ventricular failure, restrictive cardiomyopathy, or cor pulmonale. These are also important things of elevated V waves. And another important thing is A wave equal to V wave, and A wave is equal to V wave. Normally in right atrium, A wave is more than V wave, and in left atrium, V wave is more than A wave. But when there is communication between the two atrium, the A wave becomes equal to V wave. So A wave is equal to V wave is seen in mainly ASD. So this is the CV wave, and prominent V wave is also seen some other conditions. Now absent Y descent is mainly seen in cardiac tamponade and right ventricular infarction, and slow Y descent is mainly seen in tricuspid stenosis and right atrial myxoma. And prominent Y descent is seen mainly in constrictive pericarditis and tricuspid regurgitation. So this is the prominent X and Y descent in tricuspid regurgitation, and this is known as Frederick's sign. So Y descent is prominent as ventricular filling is unimpeded during early diastole, and this is interrupted by rapid raise in pressure as the filling is impeded by constricting pericardiums, and ventricular pressure curve exhibits square root sign. So, and another important thing is Kussmaul sign, and Kussmaul sign is basically a rise or lack of fall in JVP with inspiration. It is seen in constrictive pericarditis, severe right heart failure, or restrictive cardiomyopathy and massive pulmonary embolism. So I am skipping all this slide, and okay, now question on JVP. So this is my last slide. So just move on to the questions.
So if there are any questions, you can go ahead, please. To all the students, please put in your questions in the chat box.
Sir, just before the questions comes pouring in, just a request that you just summarize the important things, important slides you mentioned about the exam purpose regarding JVP. That will be perhaps helpful to the students also.
Okay, important slides. So the most important slide is JP is these two slides. Number one, can you slide a slide?
Yes, sir.
Yes,
Yes,
they are
sir.
visible.
This one is important. This one is very important. These two slides are very important. And another thing is abdominojugular reflux. The definition is very important. And last of all, different types of waves and their explanations and abnormal conditions. And how to look for JVP. The method of examination. This one. Okay.
Okay, sir. Thank you, sir.
JVP, method of examination, different types of waves, their explanations, and the difference with arterial wave, abdominojugular reflux, and the relation with the heart sounds. Okay, this much is important in JVP. Yes, you can surely get this PPT. And if sitting posture, if the pulsation, if the venous pulsation is visible, then JVP is raised. Okay. Normally in sitting posture, you should not see the JVP. You get my, you get your answer, Devajyoti?
Yes, sir. Yes, sir.
Okay, fine. Anything else?
Sir, just one question, just to mug up. Actually, I just want to know for our MBBS students, what is the better option to note the JVP at 45 or for sitting posture? Because that appeared a bit actually confusing for me. For the undergraduate level? What would be the answer for undergraduate level?
It is better to look the JVP in sitting posture, because that is easy and that is comfortable. Often it is very difficult to see the JVP in 45-degree position. Actually, Professor Shantanu always told to look the JVP at sitting posture.
Okay, sir. Thank you, sir.
And in sitting posture, if you can see the JVP, then it is elevated. It is very easy. And for seeing the pulsation, for identifying the pulsation, it is better to keep the patient in lying down position. Okay.
So I think there are no more questions. It was a wonderful session by Dr. Supratip Kundu. and I hope this will be useful to all our undergraduate students. I ask Dr. Somojyoti to give the final remarks today before we call it a day.
Okay, thanks to everybody. A special note of thanks to all the seniors who are present, along with Dr. Soumit Goswami, Dr. Amit Jana. And in the initial session, I forgot to mention the name of one of our organizers, organizer students, Krishan. He has been also very much cooperative and supportive in this project. So also, I mentioned the name of Abhisha Devabjit and others, but sorry, Krishan, I missed your name. Once again, thanks to everybody, and a very detailed and very nice explanation by Supratip sir. My heartfelt thanks to him. I acknowledge his efforts, and we are with.
And you can
Thanks
share
a lot.
the slide. You send your email, and I will send the slides. You can share.
Just a
That
word.
will be
Just
helpful.
I look forward to a word from Dr. Amit Jana, because he has been the pilot in the overall the entire project.
Okay,
Amit,
I
are you
would,
there?
I would like to thank you everyone before ending this session. Okay, and I would like to mention the next class, which will be examination of lungs by Dr. Indranil Haldar, MD Pulmonary Medicine, presently attached to JNM on 13th, 9:30 p.m. to 10:30 p.m. We will start two classes, gynecology and obstetrics classes, and probably the classes will be from 7:30 p.m. to 8:30 p.m. Okay, I think everyone has noted the next class. It will also be circulated in the WhatsApp groups and in the Facebook page of Federation of Gynecology Doctors. So I think we should end here. Is it okay?
Right.
So we will be ending here.
Okay, thanks Suraj, thanks Tuhina, and all students. I thank all the students who were also present in the session. Thanks Atrey Chakraborty.